So I think with CAR T-cell therapy, it's quite clear that there are two types of acute toxicities that are observed. One is cytokine release syndrome, or CRS, and the second is neurological toxicity, which is now called as immune effector cell associated neurotoxicity syndrome, or ICANS. Recently, the American Society of Transplantation and Cellular Therapy proposed a consensus grading system for both CRS and ICANS. And currently, it's our hope that this ASTCT consensus grading system will be implemented across all centers to grade toxicities for both commercial patients as well as patients being treated on clinical trials. So currently, for management of these toxicities for CRS, for grade 1, it's mostly supportive care. We try to rule out an infection. For grade 2 is when we typically intervene with anti-IL-6 therapy with tocilizumab on top of supportive care. And grade 3, 4 patients are typically managed in the intensive care unit, and they get both tocilizumab and corticosteroids, with grade 3 patients getting usually dexamethasone at 10 to 20 milligrams every 6 hours, or an equivalent dose of methylprednisolone, versus grade 4 patients who get up to 1 gram of methylprednisolone. Now, for neurological toxicity, grade 1 patients are again typically managed with supportive care. We try to avoid aspiration in these patients, and also ensure they get adequate hydration. Generally start them on anti-seizure prophylaxis if they're not previously on anti-epileptics. In addition, we do some imaging workup with EEG and imaging of the brain to rule out cerebral edema or seizure activity. If they have concurrent CRS, these patients can get anti-IL-6 therapy, but in the absence of concurrent CRS, we generally do not administer tocilizumab. For grade 2 is when we might intervene with 1 or 2 doses of dexamethasone. Grade 3 is when we typically use dexamethasone every 6 hours, and for grade 4, we use high-dose corticosteroids with up to 1 gram a day. Now, besides these two acute toxicities, there are also some late toxicities that can occur with CAR T-cell therapy. So one of the late toxicities that's been noted is prolonged cytopenias, with grade 3 and 4 higher cytopenias lasting beyond 30 days, has been observed in up to 30% of the patients with anti-CD19 CAR T-cell therapy on the pivotal trials. These patients are typically managed with transfusions and growth factors as needed. Now, besides that, there can also be B-cell aplasia in these patients because it's an expected on-target off-tumor effect with CD19 CAR T-cell therapy, and can lead to hypogammaglobulinemia. And patients who develop hypogammaglobulinemia in adults, we would use immunoglobulin replacement therapy only if they develop recurrent infections, in contrast to children where it is given prophylactically to prevent infections. Now, besides these two, we have also noted some opportunistic infections in some of these patients, especially zoster reactivation as well as pneumocystis pneumonia, which can occur up to 1 year or more after CAR T-cell infusion. And this appears to be because of delayed immune reconstitution, especially of the CD4 T cells in these patients. So because of this, we recommend prophylaxis for zoster as well as pneumocystis pneumonia for at least a year, and then to check the CD4 counts. If the CD4 counts are about 200 at the 1 year time point, the prophylaxis can be stopped.